Okay, so in today's class we'll be discussing about cataract. Okay, so what is the definition of cataract? It is a opacification in the crystalline lens or its capsule, which is causing decreased visual acuity, and the leading cause for reversible blindness worldwide is cataract. Okay, so it is nothing but the opacification in the lens. So as we all know, lens is held inside a capsule. Okay, so there might be crystallization or opacification of this lens or its capsule. So whenever there is opacification in this lens, obviously patient will not be able to visualize, and this, when seen the patient, it will be appearing like a whitish tissue here. Okay, so this is cataract. So this is how a normal eye looks. This is how a eye with cataract looks. Okay, there will be cloudy lens in case of cataract. So what is the classification of cataract? How can we classify cataract? We can classify it based on the age of onset. Like if the cataract is happening in a child or in a infant, then it is congenital or infantile cataract. And if the cataract develops as we develop, as we age, then there is senile cataract, which is most common. Senile nothing but age old people. Okay, so senile cataract will be seen in age old people. Then based on etiology or the cause which actually causes cataract, based on that we can say if it is due to age relation, or if it is due to trauma, or if it is complicated cataract, or if it is metabolic cataract, or if it is due to drug induced or radiation induced. Based on the etiology we can classify cataracts like this: ಏಜ್ ಇಂದ ಆಗಿದೆಯಾ, ಅಥವಾ ಟ್ರಾಮಾ ಆಗಿ ಅದರಿಂದಾಗಿ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಫಾರ್ಮೇಷನ್ ಆಗಿದೆಯಾ, ಅಥವಾ ಮಲ್ಟಿಪಲ್ ಕಾಸಸ್ ಇಂದ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಆಗಿದ್ರೆ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಅಂತೀವಿ. ದೆನ್ ಮೆಟಬಾಲಿಕ್ ಕ್ಯಾಟ್ರಾಕ್ಟ್ಸ್, ಡ್ಯೂ ಟು ಸಮ್ metabolic disorders there will be development of cataract, that is metabolic cataract. Then due to some drug which he is taking for some other condition, because of that there is development of cataract, then it is drug induced. Similarly radiation induced. The name itself says everything. Okay, and based on morphology we can say there are various types of cataracts like nuclear sclerosis or cortical cataract or posterior subcapsular cataract. Okay, so based on various things we can classify cataract as different categories. So this is shown in an infant, so infantile cataract based on age of onset you can say, and this is a senile cataract. And again, senile cataract has various types which have been shown here. We will discuss about this eventually also. Just remember there are 4 types, like incipient, this is in the initial stage of the cataract. Then it is progressing to next stage called as immature cataract. After that is the mature cataract, and then is the hypermature cataract. So all these are stages which is seen in senile cataract. Okay, again this is a cataract which is due to trauma. So this is trauma induced cataract or traumatic cataract you can say. Here just we can see there is no proper homogeneous cataract formed, like it is just haphazard and there is opacification wherever possible. Okay, this is due to trauma. And then this is the morphological classification of cataracts, just we discussed a lot. So nuclear cataract, posterior subcapsular cataract and cortical cataract. So illi nuclear andre nucleus of the lens is involved, nuclear cataract. And then posterior subcapsule, so posterior idu lens illide, lens in capsule white ಅಲ್ಲಿ ತೋರಿಸಿದ್ದಾರೆ, ಅದರಲ್ಲಿ posterior part ಅಲ್ಲಿ cataract ಆಗಿದೆ. So this is posterior subcapsular cataract. Okay, other than that nuclear, then cortical cataract. So the lens might be involved or cortex of the lens is involved, we call it cortical cataract. Okay, so this is morphological classification of cataract. After this, coming with etiology and risk factors of cataract. So what are the etiology, why does this cataract actually happen, and what are the risk factors that will lead to development of this cataract? So main cause is age related protein degeneration. Okay, so as we all know, lens is made up of protein. Okay, whatever these proteins are there, they should be manufactured in a proper way and it should be of proper composition. So as we age there will be multiple factors which we get exposed to, like UV radiation or some X-ray radiation or drugs, so many other things. What they will do, they will alter the genetics in our body such that the proteins which are getting or which are responsible for forming these lens, they will get degenerated. Okay, so if suppose the protein should be formed like this, because of all this age related, the protein will just be like this. So there is alteration in its shape, size, whatever composition, and because of that reason there will be formation of abnormal lens, which is called as cataract. Okay, so main thing is age related protein degeneration. Other things can be genetic predisposition or trauma or intraocular surgery. These all can lead to cataract, or they will pose a risk factor for formation of cataract. Other than that, chronic inflammation like chronic uveitis and usage of prolonged corticosteroids, along with that some metabolic causes like diabetes, galactosemia, all these, along with that radiation exposure. So I have discussed everything. Okay, so most common cataract is senile cataract, and for that reason age related protein degeneration is most common. After that, there can be genetic predisposition, like if the father is having, the child might have a risk for developing cataracts. So genetic predisposition will be there, which will lead to cataract formation. After that, trauma, or the patient has undergone some intraocular surgery. So once there is some damage to original lens, after that it will start healing. During that time there is more chances of developing cataract. Hence trauma and intraocular surgery poses a risk factor. Other than that, chronic inflammation of uvea, again while healing it will heal with cataract. Then prolonged corticosteroid, that is drug abused or drug induced. Then metabolically diabetic cataract antane separate ide. Okay, diabetic. And then galactosemia, this is a metabolic inborn error of metabolism where galactose is more in blood, that is galactosemia. Emia means blood, so galactose is more in blood, and that will come to the lens and accumulate in the lens, and it will form a cataract. Okay, yeah. So other than that, radiation exposure can also pose a risk factor for development of cataracts. Okay, so here are some of the metabolic cataracts which are shown. This is oil drop cataract, which will be due to galactosemia. Sunflower cataract, you can say, because of diabetic. And snowstorm cataract usually will be due to trauma or anything like that. Okay, so these are the various metabolic cataracts. Then pathogenesis. What exactly happens? Why does this cataract exactly happen? So just like I said, there will be protein denaturation and aggregation of these denaturated proteins. So what happens? Normally, just like I have explained before, there should be proteins getting accumulated in lens like this. Okay, but now this protein will undergo degeneration and they'll lose their shape. So they will get accumulated in a vague way and they'll get aggregated in the lens. Okay, so denaturated proteins or whatever are there, they are getting aggregated. Okay, so because of this reason, there will be disturbance in the lens fiber arrangement, and this will lead to change in the water content of the lens also, and then hence lens the transparency loss agutte. So everything is because of this protein denaturation. Protein denaturation agi lens fiber arrangement disturb agutte. Because of that there will be water content changes, and because of that there will be loss of transparency. This is the etiopathogenesis. Now coming to clinical features, how will the patient come to us if the patient is having cataract? So this is a gradual painless vision loss. So it won't happen in one day unless it is due to trauma or something. Even for trauma, it will take time. Once the lens is damaged and the body starts repairing mechanisms, and it will heal by formation of cataract. Okay, so it is a gradual painless loss of vision, and usually there will be glare and night vision problems. Okay, patient will be experiencing glare, just like if we are wearing spectacle and if we go and stand to the light, we will be able to see glare on the spectacle, right? So like that the patient will be seeing everywhere, like whatever he sees he will be having a glare in one corner of his eye, that is glare. Okay, along with that there will be night vision problems. So these are the two usually main symptoms which patient will come to. Otherwise, so after 40 years of age, usually there will be frequent changes of glasses, that is myopic glasses, myopic shift will be there. Okay, short sightedness ಆಗ್ತಾ ಹೋಗುತ್ತೆ. This is called as myopic shift. So after 40 years they will be changing frequently. Like ಇವಾಗ -1 ಏನೋ ಇತ್ತು ಪವರು, ಓಕೆ ಹೋಗಿ ಚೇಂಜ್ ಮಾಡಿಸ್ಕೊಳ್ತಾರೆ ಲೆನ್ಸು, ಮತ್ತೆ ಇನ್ನೊಂದಷ್ಟು ದಿನ 1 ತಿಂಗಳು 2 ತಿಂಗಳು ಆಗಿರುತ್ತೆ, ಮತ್ತೆ ಆಗಲೇ -1.5 ಹೋಗಿರುತ್ತೆ, ಮತ್ತೆ -2 ಹೋಗ್ತಾ ಇರುತ್ತೆ. ಸೊ ಮಯೋಪಿಕ್ ಶಿಫ್ಟ್ ಆಗ್ತಾ ಇರುತ್ತೆ. ಇನ್ ಸ್ಪೈಟ್ ಆಫ್ ಚೇಂಜಿಂಗ್ ಗ್ಲಾಸಸ್, still the power is decreasing, and that is called as myopic shift, and the patient will be changing frequently, changing the glasses frequently. So that history can be elicited, like after 40 years, like ಆಯಿತು ನಾನು 3-4 ತಿಂಗಳಲ್ಲೇ 2-3 ಗ್ಲಾಸ್ ಚೇಂಜ್ ಮಾಡಿದೆ ಅಂತ ಹೇಳ್ತಿದ್ದೆ ಅಂದರೆ, ಓಕೆ ದೆರ್ ಮೇ ಬಿ ಡೆವಲಪ್ಮೆಂಟ್ ಆಫ್ cataract in this patient. Other than that, what is the symptom? Monocular diplopia. Like the patient will be seeing 2 images if asked to see with the eye which he is having cataract. Okay, that is called as monocular diplopia. Like ಯಾವ ಕಣ್ಣಲ್ಲಿ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಆಗಿದೆ ಆ ಕಣ್ಣಿಂದ ನೋಡಿ ಅಂದರೆ ಎರಡೆರಡು ಕಾಣಿಸ್ತಿದೆ ನನಗೆ ಅಂತಾರೆ. ದಟ್ ಈಸ್ monocular diplopia. Other than that, leukocoria can be there in advanced cases. Like leukocoria ಹಿಂಗೆ ಈ ಥರ ಇರುತ್ತೆ. Like one eye will be whitish and other eye will be normal. So leukocoria will be there in the advanced cases. Okay, next. So just like we had discussed before, there are various stages in the senile cataract. So ಒಂದೇ ಸಲ cataract develop ಆಗಲ್ಲ, it develops in stages, and most common cataract as we know is senile cataract. So you should know a bit more in detail about senile cataract. So first one is incipient stage or early opacity. Okay, so you can say before this stage also there is a stage called lamellar separation which happens in the lens. Lamella will get separated, like lens ಈ ಥರ ಅರೇಂಜ್ ಆಗಿದ್ರೆ it is arranged in various lamellae. ಆಯಿತಾ, ಈ ಥರ ಆನಿಯನ್ ಪಿಲ್ ಥರ ಇದೆ. ಸೊ ದೀಸ್ ಲ್ಯಾಮೆಲ್ಲೆ ವಿಲ್ ಗೆಟ್ ಸೆಪರೇಟೆಡ್ 1 by 1. ಸೊ ಲ್ಯಾಮೆಲ್ಲಾರ್ ಸಪ್ರೇಷನ್ ಆಗುತ್ತೆ. ಅದಾದಮೇಲೆ ಅರ್ಲಿ ಒಪಾಸಿಟಿ ಆಗೋಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. ದಟ್ ಈಸ್ ಇನ್ಸಿಪಿಯಂಟ್ ಕೆಟ್ರಾಕ್ಟ್. ಆಫ್ಟರ್ ದಟ್ ಇಟ್ ವಿಲ್ opacify partially, and that is called as immature cataract. Okay, the mature cataract is complete opacification. Like this, entire eye, entire cornea, or whatever you can see through the cornea, the lens, entire lens is opacified. That is called as mature cataract. So these are the 4 stages of cataract: incipient cataract, immature cataract, mature cataract. Okay, before that lamellar separation. So lamellar separation, incipient cataract, immature cataract, and mature cataract. These are the 4 stages. After this, after the lens has developed into a mature cataract, and even the patient has not seeking for medical advice now, or if he has not taken treatment even after development of mature cataract, it can develop into 2 more cataracts, or it can develop into a hypermature cataract, and then it can become Morgagnian cataract also. Okay, so after mature cataract the patient should seek for treatment. Otherwise what happens, this lens might be breaking down. Okay, and it breaks down into pieces and gets accumulated here like this, Morgagnian cataract, or it will become hypermature cataract and get liquefied. Okay, so liquid agidre hypermature cataract agutte, it will break into pieces and get accumulated adre Morgagnian cataract agutte. So these are the complications of mature cataract, you can say. Okay, after this, how will we diagnose cataract? Obviously the patient will be complaining of vision problem. ನನಗೆ ನೋಡೋಕ್ಕಾಗ್ತಿಲ್ಲ, ನಂಗೆ ಕರೆಕ್ಟಾಗಿ ಕಾಣಿಸ್ತಿಲ್ಲ, ಓದೋಕ್ಕೆ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತಿದೆ. ಸೊ ವಿಜುವಲ್ ಅಕ್ವಿಟಿ ಟೆಸ್ಟ್ ಮಾಡ್ತೀವಿ. ವಿಜುವಲ್ ಅಕ್ವಿಟಿ ಟೆಸ್ಟ್ ಲೆನ್ಸ್ ಚಾರ್ಟ್ ಅದು ಇದು ಮಾಮೂಲಿ ಮಾಡ್ತೀವಲ್ಲ. ಸೊ ವಿಜುವಲ್ ಅಕ್ವಿಟಿ ಟೆಸ್ಟಿಂಗ್ ಮಾಡ್ತೀವಿ. ಅದರಲ್ಲಿ ಇಫ್ ದೆರ್ ಇಸ್ ಅ ಮಯೋಪಿಕ್ ಟೆಂಡೆನ್ಸಿ ಆರ್ ಎನಿಥಿಂಗ್, ಇಟ್ ಈಸ್ ಲೀಡಿಂಗ್ ಟು cataract. Okay, other than that we can go for slit lamp examination, which I have shown here. So slit lamp ಅಲ್ಲಿ ಎಕ್ಸಾಮಿನ್ ಮಾಡ್ತಾ ಹೋಗ್ಬೋದು. ಎಕ್ಸಾಮಿನ್ ಮಾಡಿದಾಗ ಇಫ್ ದೆರ್ ಇಸ್ ಅ cataract, it will appear like this. Okay, slit lamp usually ನಮಗೆಲ್ಲ ಮಾಡೋಕ್ಕೆ ಹೇಳಲ್ಲ. just know that slit lamp examination is done and cataract can be visualized this. Okay, after that we can go for fundoscopy, in which fundus may be examined. Okay, fundus may be obscured in this case. ಇಷ್ಟರಲ್ಲೂ ಗೊತ್ತಾಗಲಿಲ್ಲ ಅಂದರೆ we can go for B scan ultrasound and visualize the cataract. If the fundus is not visible in case of cataract, we can go for B sound, that is B scan ultrasound. Okay, after this, management. So how will we manage the case of cataract? One is conservative management. So conservative management ಅಲ್ಲಿ will not, like there is no medical cure actually. Okay, we can just correct refractive changes, like ನಾನು ಹೇಳಿದೆ ಸ್ಪೆಕ್ಸ್ ಇವಾಗ ಕಣ್ಣು ಕಾಣಿಸ್ತಾ ಇಲ್ಲ, ಸೊ ವಿ ವಿಲ್ ಗೋ ಫಾರ್ ಚೇಂಜಿಂಗ್ ದ ಸ್ಪೆಕ್ಸ್ ಲೈಕ್ ದಟ್. ರಿಫ್ರಾಕ್ಟಿವ್ ಕರೆಕ್ಷನ್ ಮಾಡ್ಬೋದು ನಾವು. ಅಲ್ಟಿಮೇಟ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಈಸ್ ಸರ್ಜಿಕಲ್. ಯಾವಾಗ ಸರ್ಜರಿ ಈಸ್ ಇಂಡಿಕೇಟೆಡ್ ಅಂದರೆ ಇಟ್ ಈಸ್ ಇಂಡಿಕೇಟೆಡ್ ವೆನ್ ವಿಷನ್ ಅಫೆಕ್ಟ್ಸ್ ಆಕ್ಟಿವಿಟೀಸ್. ಲೈಕ್ ನಾರ್ಮಲಿ ಹಿ ಹ್ಯಾಸ್ ಟು get upstairs or go down the stairs. If the patient is unable to go down the stairs, If it is causing a problem for performing his activity, then surgery is indicated. Okay, and then what are the surgeries we will usually do? We'll do usually two kind of surgeries. That is small incision cataract surgery, which was conventionally followed, and nowadays they'll perform phacoemulsification with foldable intraocular lens. IOL is intraocular lens. ಸೊ ಜಸ್ಟ್ ಪ್ರಿನ್ಸಿಪಲ್ ಏನಿರ್ಬೋದು ಈ ಸರ್ಜರಿದು, ಇವಾಗ ಏನು ನನಗೆ ಗೊತ್ತಿದೆ, ಪ್ಯಾಥಾಲಜಿ ಏನಾಗ್ತಿದೆ ಅಂತ ಗೊತ್ತಿದೆ. ಲೆನ್ಸ್ ಇತ್ತಪ್ಪ, ಆ ಲೆನ್ಸು ಪ್ರಾಬ್ಲಮ್ ಆಗಿ ಬೇರೆ ಪ್ರೋಟೀನ್ ಬಂದಿದೆ, ಇವಾಗ ಆ ಲೆನ್ಸು ಮತ್ತೆ ಸರಿ ಮಾಡೋಕ್ಕಾಗಲ್ಲ ನಾವು. ಸೊ ನಾವೇನು ಮಾಡ್ತೀವಿ, ಸರ್ಜರಿ ಮಾಡಿ ಈ ಲೆನ್ಸ್ ತೆಗೆದು ಒಂದು ಸಿಂಥೆಟಿಕಲಿ ಪ್ರಿಪೇರ್ಡ್ ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್ನ ಇನ್ಸರ್ಟ್ ಮಾಡ್ತೀವಿ ಅಷ್ಟೇ. ಓಕೆ, ಸೊ ರಿಮೂವಲ್ ಆಫ್ ದಿಸ್ ಓಲ್ಡ್ ಲೆನ್ಸ್ ಆ್ಯಂಡ್ ಇನ್ಸರ್ಷನ್ ಆಫ್ IOL. ದಿಸ್ ಈಸ್ ಅ ಪ್ರೊಸೀಜರ್. ಆ ಪ್ರೊಸೀಜರ್ಗೆ ಹೆಂಗೆ ಈ ಲೆನ್ಸ್ ತೆಗಿತೀವಿ ಅದ್ರ ಮೇಲೆ ಡಿಪೆಂಡು. ಸೊ ಸ್ಮಾಲ್ ಇನ್ಸಿಷನ್ ಕೊಟ್ಟು, ಮಾಮೂಲಿ ಬ್ಲೇಡ್ ಯೂಸ್ ಮಾಡಿ ಸ್ಮಾಲ್ ಇನ್ಸಿಷನ್ ಕೊಟ್ಟು ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಆಪ್ರೇಷನ್ ಮಾಡಿದರೆ, ಅಂದರೆ ಈ ಲೆನ್ಸ್ ತೆಗೆದ್ರೆ ದಟ್ ಇಸ್ ಸ್ಮಾಲ್ ಇನ್ಸಿಷನ್ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಸರ್ಜರಿ. ಫೇಕೋಎಮಲ್ಸಿಫಿಕೇಷನ್ ಅಂದರೆ ವಿಲ್ ಯೂಸ್ ಸ್ಪೆಷಲೈಸ್ಡ್ ಟೆಕ್ನಿಕ್ ಲೈಕ್ ಪೋರ್ಟ್ ಇನ್ಸಿಷನ್ಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಅದ್ರ ಮೂಲಕ ಫೇಕೋಎಮಲ್ಸಿಫೈ ಮಾಡಿ ಆಮೇಲೆ ಆ ಲೆನ್ಸ್ ತೆಗೆದ್ರೆ ದಟ್ ಈಸ್ ಫೇಕೋಎಮಲ್ಸಿಫಿಕೇಷನ್. ಓಕೆ, ಸೊ ಹಿಯರ್ ಇನ್ ದಿಸ್ ಇಮೇಜಸ್ ಐ ಹ್ಯಾವ್ ಶೋನ್ ಬೋತ್ ಫೇಕೋಎಮಲ್ಸಿಫಿಕೇಷನ್ ಆ್ಯಂಡ್ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಸರ್ಜರಿ. ಓಕೆ, ಸೊ ಐ ವಿತ್ ಅ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಇದ್ದರೆ ಹಿಂಗೆ ಕಾಣಿಸುತ್ತೆ, ಆ್ಯಂಡ್ ವಿ ಹ್ಯಾವ್ ಟೇಕನ್ ದ ಲೆನ್ಸ್ ಇಂಪ್ಲಾಂಟ್ ದಟ್ ಈಸ್ ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್. ಸೊ ವಿ ಹ್ಯಾವ್ ಪುಟ್ ಅನ್ ಇನ್ಸಿಷನ್ ಆ್ಯಂಡ್ ವಿ ಹ್ಯಾವ್ ರೀಚ್ಡ್ ಲೆನ್ಸ್ ಶೋಯಿಂಗ್ ವಿತ್ ದಿಸ್ ಇಮೇಜ್. ಓಕೆ, ಸೊ ಅದನ್ನು ಮಾಡಿ ಏನು ಮಾಡ್ತೀವಿ, ವಿ ಹ್ಯಾವ್ ಇಂಪ್ಲಾಂಟೆಡ್ ದ ಲೆನ್ಸ್, ಲೈಕ್ ಡಿಸೀಸ್ಡ್ ಲೆನ್ಸ್ ಇಸ್ ಪುಲ್ಡ್ ಔಟ್ ಆ್ಯಂಡ್ ಇಂಪ್ಲಾಂಟ್ ಈಸ್ ಇನ್ಸರ್ಟೆಡ್ ಆ್ಯಂಡ್ ಲೆನ್ಸ್ ಇಂಪ್ಲಾಂಟೆಡ್ ಇಂಟ್ರಾಪೊಸಿಷನ್ ಲುಕ್ಸ್ ಲೈಕ್ ದಿಸ್. ಓಕೆ, ಸೊ ದಿಸ್ ಈಸ್ ಅ ಬೇಸಿಕ್ ಪ್ರಿನ್ಸಿಪಲ್ ಆಫ್ ಅ ಕ್ಯಾಟ್ರಾಕ್ಟ್ ಸರ್ಜರಿ. ಇನ್ ಫೇಕೋಎಮಲ್ಸಿಫಿಕೇಷನಲ್ಲಿ ಏನು ಮಾಡ್ತೀವಿ, we will create a port incision, like create 2-3 mm incisions over the cornea. Okay, first incision is made in a paracentesis blade, second incision is being made with a keratome blade. Like blade, paracentesis blade ಇದಕ್ಕೆ ಹೆಸರು, ಇದಕ್ಕೆ keratome blade. Keratome blade usually will be like a diamond shaped. ಓಕೆ, ಸೊ ಇದನ್ನು ಯೂಸ್ ಮಾಡಿ ಎರಡು ಸೈಡು ಇನ್ಸಿಷನ್ಸ್, ಇಲ್ಲೊಂದು ಇನ್ಸಿಷನ್ನು ಇಲ್ಲೊಂದು ಇನ್ಸಿಷನ್, ಎರಡು ಇನ್ಸಿಷನ್ ಹಾಕ್ಕೊಳ್ತೀವಿ. ಆಫ್ಟರ್ ದಟ್ ವಿಲ್ ಗೋ ಫಾರ್ ವಿಸ್ಕಾಟ್ ಅಪ್ಲಿಕೇಶನ್. ದಿಸ್ ವಿಸ್ಕಾಟ್ ಅಂದರೆ ಏನಂದರೆ ಇಟ್ ಇಸ್ ಅ ಜೆಲ್ ಲೈಕ್ ಮೆಟೀರಿಯಲ್ ವಿಚ್ ವಿಲ್ ಬಿ ಇಂಜೆಕ್ಟೆಡ್. Okay, so inject viscot and anesthetic into the anterior chamber. Along with viscot we will inject anesthetic agent, so patient won't be able to feel anything. Okay, after this continuous curvilinear capsulorhexis is done. So using a cytotome blade we create a complex circular incision around the lens. Like ಇವಾಗ ಎರಡು ಇನ್ಸಿಷನ್ ಮಾಡಿದ್ವಲ್ಲ, ಇಲ್ಲಿಂದ ತೊಗೊಂಡು ಒಂದು ಕಾಂಪ್ಲೆಕ್ಸ್ ಸರ್ಕ್ಯುಲರ್ ಇನ್ಸಿಷನ್ ಕ್ರಿಯೇಟ್ ಮಾಡ್ಕೋತೀವಿ. ಓಕೆ, ಇಟ್ ಈಸ್ ಬೆಟರ್ ಶೋನ್ ಹಿಯರ್. ಸೊ ಇನ್ಸಿಷನ್ ಕೊಟ್ಕೊಂಬರ್ತಿದಾರಲ್ಲ, ಈ ಥರ ಕಾಂಪ್ಲೆಕ್ಸ್ ಒಂದು ಕರ್ವಿಲಿನಿಯರ್ ಇನ್ಸಿಷನ್ ಹಾಕ್ಕೊಳ್ತೀವಿ ಯೂಸಿಂಗ್ ಸೈಟೋಟೋಮ್ ಬ್ಲೇಡ್. ಆಫ್ಟರ್ ದಟ್ ಕ್ರಿಯೇಟ್ ಅ ಫ್ಲ್ಯಾಪ್, ಲೈಕ್ ಎತ್ತಿ ಸೈಡಿಗೆ ಹಾಕೋತಾರೆ, ಇಷ್ಟು ಪಾರ್ಟ್ನ ಎತ್ಬಿಟ್ಟು ಸೈಡಿಗೆ ಹಾಕ್ತಾ ಇದ್ದಾರಲ್ವಾ. ಸೊ ಜಸ್ಟ್ ಲೈಕ್ ಟರ್ನಿಂಗ್ ದ ಪೇಜಸ್ ಆಫ್ your book. So we have created a flap and we are lifting it up so that we will be able to reach lens which is deceased. After this is the main step, that is phacoemulsification. So we will break down the nucleus by creating a cross with a phacoemulsifier. Phacoemulsifier is a device which will be used to break this whatever we have created into in the mark of plus or cross. Okay, ಸೊ ಇದರಿಂದ ಬ್ರೇಕ್ ಡೌನ್ ಆಗುತ್ತೆ, ನ್ಯೂಕ್ಲಿಯಸ್ ಬ್ರೇಕ್ ಡೌನ್ ಆಗುತ್ತೆ. ಅದಾದಮೇಲೆ ಸೆಕ್ಷನ್ ಮಾಡಿ ವಿ ವಿಲ್ ರಿಮೂವ್ ದೋಸ್ ಕೆಟ್ರಾಕ್ಟ್ ಫ್ರಾಗ್ಮೆಂಟ್ಸ್. ಸೊ ಬೇಸಿಕಲಿ ಲೆನ್ಸ್ನ ಹೊಡೆದಾಕ್ದಂಗೆ ಇಲ್ಲಿ we will use a phacoemulsifier and we will just create fragments of the cataract fragments. ಆದಮೇಲೆ ಸೆಕ್ಷನ್ ಯೂಸ್ ಮಾಡಿ we will just take it off. ಓಕೆ, ಆಫ್ಟರ್ ದಿಸ್ ಏನು ಮಾಡಬೇಕು, ಇರಿಗೇಟ್ ಮಾಡಿಬಿಟ್ಟು ಆಸ್ಪಿರೇಟ್ ಮಾಡಬೇಕು ಮತ್ತೆ. ಸೊ ವಾಷಿಂಗ್, ಬೇಸಿಕಲಿ ಎಲ್ಲ ಪುಡಿ ಪುಡಿ ಆಗಿದೆ, ಅಲ್ಲೇನಾದರೂ ಬಿದ್ದಿದ್ರೆ ಅದು ಕ್ಲೀನ್ ಆಗಬೇಕಲ್ಲ ಸೊ ಅದಕ್ಕೆ we will do irrigation. Irrigate and aspirate. Use an aspiration or irrigation handpiece with a straight tip to clean the leftover cortical material. ಸೊ ಇವಾಗ ಡಿಸೀಸ್ ಲೆನ್ಸ್ನ ತೆಗೆದಾಯಿತು. ಆಮೇಲೆ ಲಾಸ್ಟ್ಗೆ ಏನು ಮಾಡಬೇಕು, ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್ ಹಾಕಬೇಕು. ಸೊ ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್ ಇನ್ಸರ್ಷನ್ ಇಸ್ ದ ಲಾಸ್ಟ್ ಸ್ಟೆಪ್. ದಟ್ ಈಸ್ ಇನ್ಸರ್ಟ್ ಅನ್ ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್ ಯೂಸಿಂಗ್ ಅ ಲೆನ್ಸ್ ಇಂಜೆಕ್ಟರ್. ಲೈಕ್ ಈ ಥರ ಫೋಲ್ಡ್ ಮಾಡಿಬಿಟ್ಟು ವಿ ವಿಲ್ ಪುಟ್ ಇಟ್ ಓವರ್ ದ ಸ್ಪೇಸ್ ವಿ ಹ್ಯಾವ್ ಕ್ರಿಯೇಟೆಡ್, ಅಲ್ಲಿ ಇಟ್ ವಿಲ್ ಸ್ಪ್ರೆಡ್ ಆ್ಯಂಡ್ ದೆನ್ ವಿಲ್ ಯೂಸ್ ಅ ಫೋರ್ಸೆಪ್ಸ್ ಟು pull the lens into place. Okay, so this is the phacoemulsification procedure. ಬೇಸಿಕಲಿ ಇಲ್ಲೂ ಮಾಡ್ತಿರೋದು ಅದೇ, ಬಟ್ ಇನ್ಸಿಷನ್ ಕೊಡೋಕ್ಕೆ ಸಪ್ರೇಟ್ ಬ್ಲೇಡ್ಸ್ ಯೂಸ್ ಮಾಡ್ತೀವಿ, ಆ್ಯಂಡ್ ದೆನ್ ಕ್ಯಾಪ್ಸುಲರ್ ಎಕ್ಸೆಸಿಗೆ ಸಪ್ರೇಟ್ ಬ್ಲೇಡ್ ಯೂಸ್ ಮಾಡ್ತೀವಿ. ಫೇಕೋಎಮಲ್ಸಿಫಿಕೇಷನ್ ಅಂತ ಒಂದು ಅಂದರೆ ಇಟ್ ಇಸ್ ಡನ್ ಬೈ ಅನ್ ಫೇಕೋಎಮಲ್ಸಿಫೈಯರ್, ಆ್ಯಂಡ್ ದೆನ್ ಇಂಟ್ರಾಕ್ಯುಲರ್ ಲೆನ್ಸ್ ಇನ್ಸರ್ಷನ್ ಇಸ್ ದ ಲಾಸ್ಟ್ ಸ್ಟೆಪ್. ಓಕೆ, ದೆನ್ ವಾಟ್ ಆರ್ ದ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಫ್ cataract if cataract is left untreated? What will be the complications? ಏನಾಗುತ್ತೆ, If untreated, this lens, whatever is there, that can lead to formation of glaucoma. Okay, so it can be phacomorphic glaucoma or phacolytic glaucoma. So idu ee lens shape alter agi, because of that shape zonules will be there, and because of that reason if there is glaucoma because of change in the shape of the lens, then that is phacomorphic glaucoma. If this lens particle breaks down, and because of that reason if there is development of glaucoma, like that lens piece can go and block the trabecular meshwork ala. So on blocking the trabecular meshwork, just like we have discussed yesterday, it will cause glaucoma. So that is phacolytic glaucoma. So phacomorphic and phacolytic glaucoma is because of as a complication of cataract. And after operating, there are certain complications, that is posterior capsular sub opacification, that is posterior subcapsular cataract anta nodidwala, that can occur because of cataract surgeries. So the most common post-op complication. At bitter, there can be fluid filled in the macula called as cystoid macular edema, that can occur as a complication of cataract. So prognosis, usually prognosis is excellent with surgery. So this is bread and butter of ophthalmologists, you can say, excellent with surgery. Along with that, lifelong follow-up for late complications and refractive error is still needed. Okay, so this brings us to the end of class on cataract.